Actually, you know what? Hold on. Go to the arrow. Okay. Nope. There we go. All right, so we will be seeing patients here. We're actually going to rent some space in Poughkeepsie. Address is to be determined, but we're looking to open up in February at the earliest and March at the latest. So we will literally be here with one of our docs up here, probably once a week seeing patients and things like that. But most important for your patients, to be honest with you, the most important thing for your patients that we'll have a monitoring station up here. So you don't have to schlep to Danbury every second or third day for like, you know, a 7-minute visit, right, at 7 a.m. in the morning. Like you should see, I show up at work about 6:30 in the morning. Patients are already lined up, right, because they know they got to get out real soon. And so the good news is we will be in the Hudson Valley as early as February and as late as March. We are very, very, very committed to the Hudson Valley, and I'm going to be up here probably, I don't want to say once a week, but maybe twice a month, 3 times a month, but we'll have my partners rotating through here. So our goal is to have a doc up here once a week for consult. So as soon as I have a formal announcement, I will totally let you know. But we're really excited and proud to be here. So if I can help anybody, you know, in any way, let me know. All right, let's get to it. So here's the learning objectives for CME. So we're going to talk about what's the evidence-based definition, because there's a million different definitions out there. What should you be checking these days? You don't have to do all that stuff. I promise you're going to love what you have to do now. And then we'll talk about some treatment options. Okay, I don't have any disclosures. First of all, let's talk about pregnancy loss in general, right? So this is theorized. This is not 100% known, but there are many traditional sources that say 50% of all pregnancies, in other words, unrecognized ones, right, result in loss. Oh my God, right? Human beings are such inefficient reproducers. We're just not good at this, right? Whereas, you know, like rodents, like rabbits or mice or rats, like every time they have sex, they get pregnant and they deliver a baby, right? Litters, right? That's why, like, you know, blank, blank, like rabbits comes from. Like that's where that phrase comes from. But human beings were just not like that. Yeah. Now, I will tell you that of clinically recognized pregnancies, a very well-accepted number is probably 15 to 20% of all clinically recognized pregnancies are going to end up in loss. But that's the baseline, right? That's the background information we have to interpret recurrent loss in terms of, right? And also, a lot of things affect it, right? Just spontaneous miscarriage, not recurrent loss. Once a woman hits about 39, 40, wow, look at that. That's terrible. That's what we deal with every single day, right? That's what I deal with every single day. All right, so we talked about why recurrent loss is, you know, really, I find one of the most toughest patient groups to work with, but I do love recurrent loss patients. I don't shy away from it. I actually really enjoy talking with these patients because I feel like I can set them straight and I have a lot to offer them, not only in the medical side of things, but also in the personal support. So we have an online support group, like a invitation-only private Facebook that's monitored. We have in-person support groups at our office. We have therapists on staff. I mean, this is all we do. And so I feel like I can really help these patients through the toughest time. And then, you know, I say to them, you know, one day you're not going to remember this pain. I promise. We'll be on the other side of this one day. And then when I'm there with them, that's the best, right? That's when you can say, see, I told you, in a good way. All right, so just every study, almost every study ever done on RPL is just fraught with tons and tons of bias and confounding and small and retrospective and looking at it from different perspectives. So there's not a lot of good evidence out there. So this is sort of where I think we all have our issues, right? This is where we have our most confusion, right? So how many losses defines RPL, right? We've heard a million different things. What type of losses count? Does a biochemical count, right? How do we evaluate? This is really, I think, what the meat of the talk is, and then what treatment options out there. But what I will say is that if you carefully look through the literature going from 50 years back all the way to 2014, which was like the last paper that I read that I thought was a really good one on this, the population risk of recurrent loss is about 1 to 5%. It's as little as 1%, as much as 5%. Probably towards the lower end in younger populations and probably towards the higher end in older populations. That just makes sense, right? But this is a number you can rely on. So if you say to patients, you're not alone, we think that up to 5% of the population has recurrent loss. That's different than them thinking they're 1 in a million, right? Because every single one of my patients, I'm sure you feel the same way when bad things happen with your patients, every one of my patients thinks they're in the 1% club, right? They think every bad thing happens to them all the time. Oh, I've never seen this before. Oh, great, that always happens to me. That's what they say, right? So you can reliably say about 1 to 5%. And there's some good, this study right here by this is the first author, but the group is a guy named William Cottee, Billy Cottee, K-U-T-T-E-H. He's probably one of the biggest writers and thinkers in the recurrent loss space. And if you see something with his name on it, it's really like that's what we like his work. And he looked at he came up with this number here after going through all the literature and doing his own studies and his own studies and things like that. So I think this is a fair number to use. All right. So all right, let's talk about how many losses. If a patient comes to you and I've had 2 biochemicals in a row, or I've had 1 missed SAB but 2 anembryonic pregnancies, 2 blighted, like what counts as how many losses do you have to have? Well, I was always taught that 3 or more consecutive losses with the same partner. So 3 or more consecutive, same partner, right? That was sort of traditional teaching when I came up as a resident. That's how we've all been trained, right? So this bulletin, which is the only document that ACOG has ever formally put out on recurrent loss, has been withdrawn. It was put out and taken back, and they've never replaced it. I don't know why, just who knows. And they said 2 or 3 or more, right? So they waffled a little bit. The Royal College of OBGYN that has a pretty influential green top bulletin. I don't know if you've ever, these things called green tops, which is like have a green across the top, and they're pretty influential. They're pretty well done. I think sometimes in Europe they do research a little bit better than we do in some areas and not others. And so, so they say 3 or more, okay? So a little more restrictive. So the ASRM 2012 bulletin, which is up here, which I think a lot of you guys took, they looked at recurrent loss as distinct entity from infertility. These patients can get pregnant, they just can't keep pregnant, right? And they said 2 or more. So they brought it down to 2 first trimester losses, and I'll tell you why. Basically, here's that influential article I was talking about with Jaslow, but it's really Billy Coute's work. Basically says when they looked at, I think, 1,050 or so, 1,030, some kind of number of losses, they stratified by how many losses they had, and if there was, let's say all the things that we would all agree are associated with first trimester loss, like recurrent loss, the ones that are investigative, that are like kind of out there, that not everybody agrees with, right, like thrombophilias and things like that, that's very nebulous, that when they stratified it, that they found no significant difference in any type, in the groups of patients with 2 losses, 3 losses, or 4 or more. So they made the conclusion that there's no difference in the workup. They're not saying what's recurrent loss and what's not, but they said you're okay to initiate your workup after 2 first trimester losses because there was no statistical difference in the patients who had 2 losses in their lab values and the patients who had 3 or more in their lab values. So you're not like being less parsimonious or wasting healthcare dollars or something like that. So you're allowed to initiate your workup after 2. That's where this comes from. So the conclusion of this document that you guys have in your hand, 2 consecutive clinical pregnancy losses. Careful of these words, consecutive, clinical pregnancy losses. So let's move on and see what that means. All right, so what type of losses, right? Clinical, what does clinical mean? All right, so, again, this is kind of a traditional thing. Williams has always said any loss less than 20 weeks. I personally think that's an arbitrary number. Like, what, 20 weeks? What's in between 19 and 21? I don't know, right? They're all pre-viable. I don't understand the difference, and I guess 500 grams here, I guess, is, a pre-viable number as well. Their green top, they said any loss less than viability. So they're more permissive in this regard, even though they're more restrictive on the other slide. But we have babies who live at 23 weeks, right? Is that going to change? I don't know the answer to that, but that's what they say. And ACOG has, in that bulletin in 2001 that's been rescinded, said any loss less than 15 weeks, which I find to be a very arbitrary number as well, right? It's not the first trimester, which would be a decent cutoff, right? It's middle of the second trimester. Like I don't understand where it came from, but these are some things. So in conclusion, I think that after we look at this, the only sort of American-based society technical bulletin that we can kind of rely on is this ASRM 2012 one. And basically they say any clinical pregnancy documented by ultrasound or histopathological examination, which I guess means D&C specimen or some kind of villi on top or something. But that does include, be very careful here, that does include a blighted ovum now, right? Because you can have an embryonic pregnancy, right? You can have an empty sac, but it's there, you see it. So interesting. But they are careful to say that failed pregnancy is less than 20 weeks. So it's basically very permissive in that regard. Any failed pregnancy under 20 weeks. Now, it looks to me like they're sneaking in a biochemical here, right? Any loss less than 20 weeks, except that they're not because they say ultrasound and histopath, right? And I don't think anybody would agree that a couple of betas equals histopathological. I don't think anybody would agree. Although there has to be an implantation somewhere. There has to be, right? If the beta's 100, right? But I don't think it does. I would say that the biochemical losses are probably half of them are due to poor implantation, right? So This is what I do all day long. Just an embryo that's trying to hold on, and it doesn't, right? I would say that half of them are probably poor implantations for reasons that science doesn't understand. We don't know a lot about implantation right now compared to the other stuff we know about. And probably half of them are aneuploid losses, chromosomally abnormal losses that are of the non-common chromosomes, right? So we all know, this is a board's question I teach the residents, we all know that the most common sort of like abnormalities are going to be trisomy 15, 18, 21, 22, and the sex chromosomes. Did I get that right? 16, yeah, thank you. So those are like the most common ones. The other ones, though, so now what we've learned from the PGD arena, when we do aneuploidy screening on embryos, so these are blastocysts that haven't even implanted yet, so they're the earliest. So when you look at the spread of aneuploidy and blastocysts that haven't even gone in yet, you'll see a complete smattering of all the chromosomes. There's actually less selection than in conceptuses because they're the ones that can implant and like grow a little bit, and that's where you're going to see your 15, 16, 18, 21, 22 sex chromosomes. So I think that the biochemicals are probably losses of the less common chromosomal abnormalities. That's what some of the literature is suggesting. I don't know if that's proven, but that's sort of like high-level sort of expert opinion from guys like who write these papers. Okay, so this is the definition I use right now. I say 2 pregnancies, 2 losses, basically, is what I say. 2 losses. Okay, now here's the meat of our talk. How do we evaluate these patients? I mean, this is what we spend our days thinking about, right? So this is what I do when every new recurrent loss patient walks through the door. First of all, I get to know them, and I say, I'm really sorry you're going through a hard time. This is terrible. We can help you through this. You know, be nice about it, right? So then I say, guys, look, 5 to 10 years ago in the old days, and I always get the laugh, the workup we'd have to do for a recurrent loss used to be this long. I'd have to do so many things, and you're going to give me 20 tubes of blood. And they all, I say, but look, in the last 5 to 10 years, there's been some really good research in well-regarded, highly respected medical journals like the England Journal and all these other ones. It's not this big now. They're like, oh, phew, not this big. So what has changed, right? Well, I can tell you, and I'm going to talk up here, and then I'm going to prove it in the slides, that thrombophilias have absolutely zero association with first trimester losses. I don't want to hear MTHFR. I don't want to hear factor V Leiden. I don't want to hear prothrombin, the G2010-1A. I don't want to hear any of that, right? There's nothing antithrombin 3, protein C, protein F. I don't want to hear any of it. None of it has been disproven in the last 5 to 10 years in good research that there is absolutely no regard. I don't even check thrombophilias. Literally, don't even check. Now, it takes me 5 minutes to explain to them why I'm not going to check it, because they're very self-educated on the internet and they're very ardent, and they're going to think I'm a quack because their brother, sisters, cousins, college roommate saw some guy who's checking it, right? And by the way, he owns a lab that he's checking it in, right? But it takes me 5 or 10 minutes to explain why, but I don't even check it, right? And that's like a big, I feel like it's a big burden lifted off of me, right? Because you're going to find something, right? You're going to find something. If you ask 20 questions, you're going to find an answer, right? And then do you act on it? Do you not act on it? And now they think you're a real quack because you found something, but you're not acting on it, right? So that's one thing. The other thing is the autoimmune disorders have been completely also debunked in the last 5 to 10 years. I don't even check autoimmune disorders, with one exception, which I'm going to get to. So I don't want to hear about lupus. I don't want to hear about Sjogren's. I don't want to hear about rheumatoid arthritis. I don't want to hear about, like, what's that one that we don't believe in? Fibromyalgia, that one, right? Sorry. You know, so I don't want to hear about any of that. None of that has been associated, right? So the thought process used to be, right, I just forget it. So, right, too pretentorial, right, yeah. So I say to them, I said, the thought process that your immune system is somehow attacking your placenta and it dies on the vine, not true. It just doesn't compute. It's been shown, it's been disputed very well in good literature, with one exception, which we're going to dive into, and that's antiphospholipid syndrome. Those randomized controlled trials from the late 90s have never been disproved, and you can still anticoagulate them. I'll show you that in a little bit. But that's it. That's the whole talk, by the way. Yeah, that's the whole talk. So let's just do this. Okay, so here's some proposed etiologies. This is everything I've ever learned about that could possibly be involved, right? So embryonic aneuploidy, so this 2 to 5% goes down here. It's in the wrong spot. Embryonic aneuploidy is always the answer. Always. Now, it doesn't mean we can find it all the time, right? So even if you do microarrays, I hear you guys talk about microarrays. So that's what we do in our losses too. So microarrays, they can go down a certain megabase pair size of segmental deletions or insertions or translocations or something like that, but they can't go to be below a certain level of detection, right? So they're not the end-all, be-all. There are lethal micro-deletions and micro-duplication stuff that we don't know too much about, right? That you can't see. Now, you're not gonna do a whole genome amplification of a conceptus. That makes no sense.
Next year.
5 minutes from now, yeah. So anyway, the answer is always aneuploidy until proven otherwise. That's how I feel, okay? Now, parental chromosomal translocations, so we know what we're talking about, right? So people with balanced translocations, Robertsonian translocations, or weird inversions, or things like that. Now, they could walk around and be totally normal, sophisticated, cool people, but if they have some form of translocation, right, the math is a little fuzzy, but it goes something like this. And geneticists do this talk better than I do about translocations, but of every 16 different ways that chromosomes can segregate, there's about 16 different things. And help me out here, Adele. I know you're smarter at this than I am. In translocations, about somewhere between 1 and 3 of them are going to have alternate segregation that is viable and balanced and can be compatible with human life. The other 13 to 15 of them are completely unbalanced and incompatible with human life. So think about that. That means of all 16 possibilities of their gametes, they have like a 1 to 3 shot, right? So that's why these people have 4, 5, 6, 7 losses, right? Now, luckily, these things will be picked up in POC, right? So if you do chromosomal analysis on POC and it's due to a chromosomal translocation, it'll be picked up. So that's the good news, right? But I mean, these are people with the heartbreaking stories, right? These are people who have been blown off for a long time, and then finally someone does a karyotype on them, and they're like, oh, here's the answer. We can fix that. So you do PGD for that. So
single analysis to figure out how to fix it?
That would be awesome, but now you're talking about not quite gene editing, but something close to it, right? All right, so 2 to 5% of patients with RPL are going to have some kind of parental, either paternal or maternal problem, okay? 2 to 5%. That's actually not that high. You think all recurrent loss patients are going to have a translocation. They don't. 2 to 5%, okay? All right, anatomic. All right, this is where a lot of the money is, right? So fibroids, Ashermans, or even not sub-Ashermans, just adhesions that aren't Ashermans, mullary anomalies like septums, by Corn, all that kind of stuff, absolutely. So if you look at every study out there, this is the range of recurrent loss. No.
In a balanced translocation patient, what is a balanced translocation recurrent loss?
So what?
Depends on the specific one, but in actuality, it's under 10%. 1 to 10%.
Wait, say it again?
It depends on the specific.
What's 10%?
Under 10%.
So the number of losses that you see overall in that population, balanced Robertson.
So I think it depends on the translocation, yeah. Because there's some that are better than they're worse.
14, and it's usually less than 10%.
And
419. Adhesion is 419.
I don't know that one off the top of my head.
each one's got its own separate thing, and I will say that we know that translocations are worse whether they come from the maternal side and the egg side, and when they're better on the sperm side for reasons that we don't really understand so well. I'm a little uncomfortable with that 10% number. I think it's higher than that, but I'd love to talk about it.
The 13, 14, the woman is 10% appreciated loss.
So that means that of all clinical pregnancies they have, only 10% of them are going to be unbalanced?
So 90% will be normal?
No, not they're going to be unbalanced, but they're going to be lost. Because the trisomy 14s don't usually even get appreciated.
I see what you're saying. Okay. All right. Yeah. All right. So, but there's still the risk of alternate segregation in those 16 chances. Still only about 1 to 2.
Only 2 are
alternate.
balanced.
Yeah, only 1 to 2 are alternate. You're exactly right. Yeah. Is that cool? So, do you want to? Yeah. All right. So.
You just have to find an answer to this issue.
Yeah. So the uterus is bad. The uterus can be a bad actor here in terms of loss as well. I mean, I can't tell you, Ashermans, I see them all. I see all the Ashermans patients. We see adhesions. We see, even there's some appreciation now that deep arcuates, which have always been considered a variant of normal, that there might be some sort of abnormality at the fundus there causing some slight increased risk over baseline for losses, but certainly septums. Absolutely yes, septums, and we all know why, right? The septum is, and I have some cool pictures. They're covered by the same endometrium that the rest of the uterus is covered on. So they're just as likely, maybe even more likely because they take up so much surface area of the uterus, to have an implantation. The problem is as soon as the trophoblasts invade in, they're probably going to find a fibrous collagenous, fibromuscular kind of thing rather than a vascularized muscle, right? You cut into these septums, you guys all know that they don't even bleed, until you get to the top and they start to pink up and you'll start to see a little more bleed. They don't even bleed. So it's like, they're trying to placentate into a desert, right? It's just not going to work. I find those very satisfying because I can fix that. That feels great, I would say septum surgery, I always tell my patients, I always say, look, think you need 2 surgeries, and if you only need 1, you're lucky. About 50% of my patients I'll take back to just get it perfect, because you really it's better to cut, 1 bite too little than 1 bite too much. We all know that. And so you put in a balloon, you estrogenize them for a month, you put them on some antibiotics, all that kind of stuff. All right. I'm actually giving away all the slides up front, so why don't we just look at this list and move on? I would say that we're going to talk about these. These all do have an effect. This is nope, no way, infection, I don't even check, I don't do biopsies, I don't check for chronic endometritis, I don't treat. It's very old school, it's very traditional, and there is wisdom in the old school stuff about ureaplasma and listeria and things like that, but it has been truly disproven in a lot of studies, so I don't look at that anymore.
Look, the funky statistic about, in the old definition of 3 consecutive losses, that you would have a significantly higher rate of carrying on that 4th pregnancy still hold?
Yeah, absolutely. So when they look at number of losses, what your chance of delivering to a live born the very next pregnancy, even up to 5 losses, the next pregnancy usually has about a 60% chance of going to term. Would you agree with that, Kim?
That's still true, huh?
Yeah, absolutely. I think I have a slide. Well, I mean, it's like banging your head against the wall and expecting something different to happen, right? Yeah.
Interesting.
Yeah. And so the funny thing is that we're going to spend all this time talking about all these fancy things. Guess what really causes loss? Smoking, obesity, bad habits, right? That's what really causes losses. No, you can't tell that to a patient, right? But try. Yeah. All right, we're going to talk about this, no way. No way, no way, no way. Idiopathic, over half of the recurrent loss patients are idiopathic. You'll never find out why. And then these are the real ones. This is literally what, if we could fix this, I have patients who have had 5 losses in a row, like in gastric bypass surgery. They get pregnant on their own and deliver to term, like that. Their SED rates are lower, their CRPs are lower. I mean, obesity is such an inflammatory state. And I personally think a lot of it has to do with this. I have a friend who's an OBGYN who she had literally 5 losses. I convinced her to do gastric bypass surgery. She got pregnant by accident 6 months afterwards, and I was really pissed. And her surgeon was really pissed. It was the best pregnancy in the world. It was great, All right. So, this is that paper I keep on alluding to. When you look at all the different types of things and you try and stratify out, you do find things wrong. And again, no difference in how many losses they've had. And this is, you see uterine anomalies definitely in patients with more losses rather than the control population. Antiphospholipid stuff, probably a little bit. I don't think it's that strong a relationship. No, right? Look, this is the same number here. Probably something to do with thyroid. We'll talk about that. But it's just interesting. So this is the paper you have in your hand, and this is what a lot of my counseling is on. And actually, you know what I do? I print it up and give it to patients. Say, you don't believe me? Read this. Follow up all the articles, Absolutely. And I think they appreciate having something in their hand. But I have like a stack of these, and I give them out when patients come in. This guy, Billy Coutet, he's a recurrent pregnancy loss center. I mean, it's an REI practice, but he has always, for the last 25 years, had a real interest in recurrent loss. And so when he talks, people listen on the subject. Let's see. So we do believe that in patients with true recurrent loss, remember, what is true recurrent loss? Recurrent loss is losing euploid embryos, right? That's true recurrent loss. You're supposed to lose aneuploid or chromosomally abnormal embryos. So there are definitely studies out there like this one that show that in women with RPL, the incidence of aneuploidy in their POC is definitely lower than in patients without recurrent loss. So we know that. So this is just a level of evidence here. So here's something interesting. So we do know that when they looked at the frequency of the different chromosomal abnormalities, right? The sporadic miscarriage cases versus recurrent loss patients, it's about the same, right? There's very little difference here in sort of the spread. So it's nothing special about like one chromosome or the other that's going to cause a problem, right? Here's some of the segregations that we were talking about here. So 3 to 6, 2 to 5. I mean, these are just similar numbers. These are the most common ones, and they have to be balanced. Otherwise, then the patient themselves wouldn't be alive if they were had an unbalanced translocation. So there you go. This is what I really like to talk about. I have some cool pictures here. So HSG is where we pick up a lot of these, at least screening. I don't love HSG as my tool because we've all been fooled by arcuate septum or septum masquerading as bicornuate. We've all been fooled by that, right? Like you look at the HSG, there's no way that's not going to be didelphys or bicornuate. Guess what? It's just a small septum. I can't explain it, but they just look different on these types of images. But that's a really good picture there. Here's some adhesions in here on the side. That's not a great picture. But a quarter of all patients with RPL are going to have some problem in the uterus, probably 5% of the whole general population. It's just that they can get over it for other reasons. These are the big ones. Fibroids, all right? We're going to talk about fibroids in a sec. Ashermans or sub-Ashermans, right? This is what I tell my residents. Ashermans is, the definition of Ashermans is complete obliteration of the uterine cavity, right, with no menses. We throw that term around a lot. Ashermans itself, like true Ashermans, is pretty rare, and you kind of know who they're going to be. 5 DNCs, endometritis. I mean, we know who they are, right? But you can have endometrial adhesions that are really bad, that you still have a period from, that because there's patchy lining in there as well, right? So how do we diagnose it? Well, we all have our own sort of pet ways to do it. I mean, my main diagnostic modality is saline sono. I can't live without saline sonos and the 3D saline sonos. I know that people who trained me liked HSGs better just because I was a little older school, and we used to rely on MRI to diagnose Mullerian anomalies. ACOG in their last statement, which I think came out in 3 years ago, 2011, end of 2011, begin 2012, said that the diagnostic modality of choice for Mullerian anomalies is now 3D saline sono, not MRI anymore. So it's just what I'm used to. It's just how I like to look and things like that. So here's some, that's a cool picture, right? So you can see, here's the septum. Now, this is a pretty small septum. I mean, we've all seen the septums that kind of, dominate the entire cavity, right? But these are sort of the reasons why. Very common. There's been no real level 1 evidence, but there's a lot of smaller studies up here that do show an increased risk of miscarriage. One of the controversies I think exists with septums is if someone's been diagnosed with a septum but hasn't had a loss yet, do you take that out? Right? I think that if you want to actively manage a Mullerian anomaly, you would probably take it out, especially if it's a big one, even if they haven't had a loss yet. But there are definitely a lot of traditional sources, a lot of textbooks, and a lot of wise people who say, look, she hasn't had a loss. Make her prove she has a problem before you operate on her. Right. Now, look, we're not talking about open heart surgery here. We're talking about hysteroscopy. So, at this point in my career, I'm not as young as I used to be. I can look at a septum and know this one's got to come out versus that one, hey, let's live with this one a little bit longer.
But there are so many people with septums who do well in pregnancy.
Exactly, especially in subsequent pregnancies, right? Yeah. They're going to, right? And don't forget, there are septums that are more vascular than others, right? There are muscular septums rather than fibromuscular septums, right? And we've seen them. Like sometimes, every once in a while, you'll get into a septum, you start cutting, it's like bleeding like crazy. Like, oh, this one might not need to come out, except that it's dominating the whole cavity, right? So I like these, though, because you can really make a difference for a patient. I've taken out septums, and then they do great after 5 losses in a row. I'll remember this case for my whole career. I was right out of fellowship, and a patient who was like super cool and charismatic that I really got along with had a 25-week preemie, and subsequently was found to maybe have a Mullerian anomaly, and came to me, and I was like, oh my God, you have this huge septum. This is great news. This is awesome. We'll take this out. You'll do great. And she said, like, why are you so happy that you found something wrong with me? And it kind of tempered my response, right? I guess I was like so excited to like use this training that I just graduated fellowship. I got it, and we took out the septum. She did great, And but don't forget, they might do better subsequently, just like the unicornuates and the bicornuates and the didelphys. Subsequent pregnancies do better because they stretch, right? I mean, we know that. I recently saw a patient who had didelphys uterus, had 3 kids in her early 20s, had didelphys uterus, had 2 in one, 1 in the other, and had 3 C-sections, but 2 on one horn, 1 on the other. And now she's in a second marriage at 42, and that guy, she married a younger man who's got no babies. So you know what she's got to do. All right. Okay, this is just a picture. So this is a little septum. This is sort of, and this is, right, we get that. So this is my image. I love this image. And you can actually tell there's like a little thing here, and there might be attached to the cervix here. We whacked this thing out, and it was great. All right, fibroids. So here's the thing on fibroids. There is a consensus of opinion that all submucosal fibroids should come out. We know for fertility and pregnancy loss, they should come out. That is consensus of opinion, both good studies, bad studies, and committee guidelines and everything like that. Ones that are external to the uterus, probably everybody agrees they don't have to come out, unless they're symptomatic. That's a different story. The ones that are intramural, that's controversial, and we kind of decide that on a case-by-case basis, right? So you can look at some fibroids and know they don't need to come out. We all know which ones they are. If you look at others that, while they're not in the cavity, they're definitely extrinsically compressing it, right, or something like that. And so I think on a case-by-case basis, you decide which mural ones need to come out. But definitely, you know, some mucosal ones, take them all out. It's bad for everybody. There's no good way to get pregnant with a submucosal fibroid, right? All right, polyps. That's a little dicier, right? I mean, we could all come up with a reason why polyps might cause loss or decrease fertility, you know, foreign body reaction, you know, kind of like an IUD reaction, something like that, or we think that there's focal aromatase expression, overexpression in it. That's why they grow. So maybe that has some kind of like weird hormonal sense, like focal defect or something like that. In the fertility side, we know that there's a good reason to take out polyps because we know that they'll decrease implantation rates. Miscarriage, I mean, observational studies, but no good studies. But I would say that, you know, if someone has some losses and they have a big polyp, I would take it out. Right? All right, let's talk about this. So thyroid disease, without boring you with like 400 slides on this, hyper and hypothyroid is definitely increased loss. There's no doubt about it. Would you agree with that? I mean, I think that, I don't mean like you know, my TSH is 4.4 and it should be, you know, I don't mean that. I mean real true hyper and hypothyroid has absolutely been associated with early loss and late complications. I would say like maybe abruption or something like that, and maybe a few other things. So, right, especially hyper. Yeah, I hate hyperthyroid. It freaks me out. I co-manage them. Hyperthyroid patients make me very nervous. Hypo, not a big deal. I feel comfortable managing that. But I would say this is the bottom line of thyroid in our office. So we are so obsessive compulsive about TSH levels. So in the REI world, where we all would give, you know, a couple of fingers off of our hand for more percentage points in our pregnancy rates, right? We like our TSHs between 0.5 and 2.5, all right? And so we medicate people who are literally normal, between 2.5 and 4.5. They're literally normal. You know, I'll give them a whiff of Synthroid, right? Medical endocrinologists agree with this, by the way, on the fertility side.
The internal medicine people don't.
Right.
And I have people who are for 4.5 and they won't do anything to them, and it drives me crazy.
Especially with the antibodies, makes me very nervous, because the antibodies actually have some weak association through lower level evidence that it can increase losses. But so I tell patients, I say, look, you do not have a thyroid condition. Your thyroid is 3.7. That is normal. And if you go to your primary care doctor, they're going to call me a quack for medicating you. I tell them this up front because I don't want to be called a quack behind my back. But I Synthroid them. I mean, absolutely. So on the fertility side, the pregnancy side, we know you'll do better between 0.5 and 2.5. There's no doubt about it, right? That's true. The question.
Guidelines for the TSH by trimester.
That agree with you, you know,
yeah.
That the American Thyroid Society came out. So they should know, because it's their own guidelines.
Right.
And the first trimester cutoff is 2.5.
Yeah, the med endo guys know for the most part. The older med endo guys don't know, but the younger med endo, like 50, 55 and below, they know that. The older guys don't necessarily know that. I can't. I'm just moving on. Moving on. And so the question comes up, does anything to do with miscarriage? And there probably is something to that if they're absolutely, truly hypo or hyperthyroid, absolutely associated with miscarriage. Whether miscarriage is increased between 2.5 and 4.5, I don't know if anyone can look you in the eyes and tell you that, although my feeling is it is off of like smaller, less good studies. Is that a fair way to put it? All right, diabetes, we absolutely know that poorly controlled diabetics have way increased risk of loss, way increased. Can I tell you guys a story? I have a patient, husband was diagnosed by hemoglobin A1C by his primary care doctor. I saw the piece of paper. His hemoglobin A1C was 17.
Oh.
I actually said, how are you alive? And he goes, that's what my doctor said to me. Have you ever heard of that? 17. I've never heard of that. He says, oh, I'm in much better control now. It's 12. Meanwhile, I diagnosed his wife with diabetes, her hemoglobin is 9.1. I think they just find each other, right? All right, anyway.
What they eat.
What?
They both weigh
Actually, no. Her BMI is, let's say, 27. So overweight but not obese. Isn't that crazy? So, all right,
Diabetes is so bad they can't put on weight.
That's right.
That's a good one, yeah. So prolactin, there is one study out here that suggests that hyperprolactinemia can lead to slight increased risks of loss. I think it's probably through a supposed luteal phase defect, because if your prolactin's high, you're going to have, no problem, don't worry, it's okay. No, don't worry about it. Take the handouts though. If you don't take the handouts, if you don't have one. Okay, good. I think that high prolactin probably decreases LH, and LH is what drives the corpus luteum, which is what gives you progesterone. But luteal phase defect is a very nebulous topic, and I could give a whole hour talk on luteal phase defect as not being a real entity anymore.
Thank you.
So, there might be some patients who literally do have some form of luteal phase defect, but we don't know how to diagnose it anymore. We don't know what the definition is. We don't know how to diagnose it. We don't know how to treat it. So if you're worried, just throw progesterone on somebody. I don't think it can help for her, right? So maybe this and this are, say again? Yeah, that's for sure. So, there's one study. It's actually level 1 evidence, but all right, let's keep on moving on. All right, so here's some TSH stuff, right? So, you can see it, right? It's there. There's a good p-value. This is one test. Here we go. I mean, I guess there's some good level 2 evidence to go on. All right, antibodies make me nervous though. The TPO antibodies are probably going to get you for miscarriage. So I do treat for. I'll give a slight. This is unencumbered by evidence, and I apologize for giving something that is not on a good slide with a good thing to say. No, I do not. There's data that we don't do, and I'll talk about that. There's a slide on prednisone in a sec. For my patients whose TSH is above 2.5, but 2.5 to 4.5, I'll give 50. Okay. For my patients who are in that range but have positive antibodies, I'll give 75. Please don't ask me why. I don't know. It's just sort of our practice protocol. It just feels better. I don't know what to tell you. Okay. Because the TPO antibodies are the worst. All right.
What if it's in range and they have TPO antibodies?
Very controversial. 25. Very. I like that answer. That is very controversial. I would say that some REIs would treat and some would not. We do not. If the TSH is dead normal, but I will check them often. I'll check their TSH a lot because those people are going to wax and wane. You know they are. So I'm looking to treat them, but I don't until it's outside the range. All right, infectious. All right, guys, listen, you can totally rely on no association. I don't do endometrial biopsies for endometritis anymore. I don't culture for ureaplasma, mycoplasma. I don't do any of that. It's freeing. You don't have to do it. There are still doctors who do, and I won't say that I would say that they're unencumbered by evidence, but I would say that it is traditional teaching for a long time. And it kind of makes sense, right? It kind of makes sense, but it's not associated with miscarriage, so what are we treating? I put a red bar around it. Must be important. Okay. So this thing called Sperm DNA Fragmentation. So you can do these very fancy tests called Tunnel and Comet, where you can look at sperm, and you can't use the sperm that you're testing because you have to actually get the DNA out to test it, and you're looking at fragmentation, like the histones and like the way it's wound and everything. You can be nicked and fragmented and not high-quality wound. That is a test in search of an indication right now. We don't know what to do with it. So right now it's not currently recommended by anybody. All right, here, antiphospholipid syndrome. So the antiphospholipids actually have it has been shown in vitro, in good studies, in histo studies, and in vitro studies, and in labs, that antiphospholipids will have bad things to do with invading trophoblasts and everything. They also, it's not up here, but they absolutely inhibit the secretion of beta-HCG by the trophoblasts. They've been shown in vitro to do so. There's a lot of biological plausibility to this, right? Now, this is considered an acquired thrombophilia, not an inherited thrombophilia, right? Because you get it later on in life just through living. But this is good level evidence, okay? There are, you have to have both of these, right? And I always pimp my residents on this, and they're taking their creogs next week, so I'm doing resident review, seems like every night after work with them. And so, there's definitely test questions in here, but this is a subtle point, and I just mean to get this out there, that the definition of loss, of recurrent loss, is 2 miscarriages, but for Antiphospholipid syndrome, it's 3, to get the diagnosis of APF, it's 3 first trimester miscarriages or a second trimester loss or a third trimester loss or something bad happening, severe preeclampsia or HELP or something like that, or IUGR.
Often 5 of it.
Well, what I'm trying to say is just to get the diagnosis of APF, to have the clinical criteria, you have to have 3 losses. 2 doesn't count for the diagnosis of APF. Just a subtle point that I try and get across. Now, the laboratory criteria, there's ones that we all agree on, lupus anticoagulant and IgG antiphospholipids. The controversial ones, I'll show some other slides, are IgM, IgA for antiphospholipids, antiphosphatidylserine, prothrombin gene mutation, the beta microglobulin, like those are a little more controversial, okay? Inherited thrombophilia, absolutely not. I don't believe in them. Don't even check. It's not worth it. It's just a waste of time. Although it might be easier giving them the lab slip than talking to them about it for 10 minutes. I don't know, but that's what I do, right? That's what I do. All right, I convince them out of it, and then they're either going to think, they're either going to believe me or they're not. I either establish a rapport and authority as an expert, and they're going to believe me, or they're going to go to somebody else who's going to test them. I don't know, but I spend a lot of time talking about this. Okay, you're going to find a lot of chat room stuff, a lot of patient self-education around natural killer cells. Look, I'm not like right. It sounds really
killers.
So right. So I will tell you that we could talk for a lot longer than I plan to on natural killer cells. Here's the bottom line. There may be something here. There may be something here. Okay, because in vitro there are some things there. However, we don't know how to test for it. We don't know what the results mean, and we can't treat for it.
So let's move on.
And peripheral natural killer cells that you can get off of blood have nothing to do with the uterine and the endometrial natural killer cell population. There's Th1s and Th2s, and the ratios differ, and there are actually different isotypes of Th1, Th2 in the endometrium versus the periphery, like plasma. So, I'm not going to reject it out of hand. I think that smarter people than me will work this out over the next 5 or 10 years. But as of right now, it is quackery. Let's just put it that way. It is quackery to treat somebody for this, although I think there's something there biologically plausible. I really do. It's just quackery to treat for it right now. And the people who are treating for this, they call themselves reproductive immunologists. I don't know what that is. I don't know how to actually get a certification in that. I don't know, there's a fellowship alive in it. Like, I don't know who they are. I don't know how you become a reproductive endocrinologist. I literally, so they're giving, yeah, they're giving IVIG. They used to do this thing called paternal leukocyte antigen infusions, which the FDA shut down because people were like dying from it. And in Philly, I think something bad happened too. But basically, IVIG is not benign either, by the way. It's a pooled product. Like for, I don't want to go into so much detail. My daughter was sick when she was like 18 months, and she got like 4 infusions of IVIG. I still think about that. I'm like, oh my God, maybe she got some like crazy like virus from, I don't know. Who the hell knows? But yeah, who the hell knows? So it is right now. It is quackery. It is absolutely quackery. It is quackery to treat natural killer cell issues, okay? And these guys prey upon this patient population online. I'm telling you that right now. They prey upon it.
That was for many, many years.
Yeah. Yeah. Guys in the city, there's a guy, really a predator online from Long Island. I don't want to say any names. Not good. Not good. And they're trying to sell their infusions, and and by the way, all of the testing they do, anti-ovarian antibodies, anti-this, anti-that, natural killer cell, all this kind of stuff, by the way, it's their own lab. Yeah. They're charging like $2,500 for the tests, right? They're preying on these patients.
Those labs to California. I mean, I don't know if you remember, but for many years, when we were in the office of Fred Hurst, 16 years ago, they were doing it. We sent them to California. Right. And then they used to go down to Philadelphia or Boston for the treatment. Yeah.
So, I mean, I really like just tell your patients it is quackery and fringe medicine if someone's trying to take their money. That's what I do. All right. So, all right, I could go into this, but I don't think I think I gave you the punchline, right? So, I have a lot of slides on it, as you can see. All right. Guys, this is what's going to help your patients, get them to quit smoking and lose weight. Oh, my God. This will literally help them. So I am the gastric bypass whisperer. I am literally the gastric bypass whisperer. I'd say in the last 5 years of practice, I have convinced probably 15 women to do gastric bypass, and I'm proud of that, right? The problem is when they're like 39 and they need it, but you have to wait a year. I mean, that's impossible. So you know what I do? and I've done this now. I'm getting smarter in my older years, right? So I have a patient literally right now. This is a terrible story. So she is a beautiful woman, really well put together, the most just sophisticated, cool, charismatic, the type of patient you walk in like, this is awesome, I'm going to get along with her, right? And she's always been heavy. She did the lap band, which I can't stand. I hate that. She lost 75 pounds like 6 years ago, was happy as a clam, except that she then got intolerant of the band and was throwing up every day and they had to take it out. She begged them to do a gastric sleeve while they're there. She said that would be unethical because you're not heavy anymore and I'm not going to do bariatric surgery on someone who's thin. I get that. Guess what? She gained 150 pounds after that. So she goes to sleep every night thinking about it, wakes up every night thinking about it, right? I mean, that's just who she is. She cries at the drop of a hat when I say good morning to her, right? I mean, it's just that's who she is right now. So she's 38, her AMH is about 0.5, I don't like that, her FSH is like 12.5, I don't like that, her antral follicle count's not that great, maybe 4 on each ovary. So she's someone who has diminished ovarian reserve and might need therapy, needs reproductive care no matter what. But she's sick about her weight and emotionally and psychologically needs to have gastric bypass, right? So she can't wait the year, though, because I proved that she's diminished ovarian reserve, so we split it down the middle. I'm putting her through IVF now. We're going to freeze embryos for her so her clock stops ticking. She's going to come back to me in a year, hopefully gets pregnant on her own, but if not, we've got beautiful embryos. Euploid embryos. Awesome. So we're splitting the difference. Pretty cool. Yeah. She's like, oh, my God, can you do that? I'm like, yeah, let's do it. All right, cigarettes, I don't need to tell you that. We all know that. NSAIDs, interesting. The biology behind this is that ovulation we know about, but also implantation is a very interleukine and leukotriene and arachidonic acid-heavy process. Like I did one of my thesis projects on microarrays of interleukins and IL-6 and LIF and all this kind of stuff on the endometrium. And so if you knock that out with NSAIDs, who knows what's happening to the trophoblastic invasion, right? They can be blunted, you might not be holding on so strong, things like that. So this is an interesting one. So fertility is impaired with over about 100 milligrams per day of caffeine per day. So in big observational epidemiologic studies, no, excuse me, not 100, 200, just 2 cups of coffee. So I say up to 1 or 2 servings of caffeinated beverage is okay for trying to get pregnant. I'm like, are you sure? I'll go without none. And this is what I say, and everyone in this room will agree with me. I said, every OBGYN I've ever known has drank coffee while she's pregnant. So then they believe me. Right? Exactly, right? But over 200 impairs fertility. And it turns out there's some data that over 300 might increase miscarriage risk. I don't think we know why, but it's plausible, right? We get that. So,
how do you treat antiphospholipids?
oh, okay. So let me get to treatment in a sec. But basically for documented true antiphospholipid syndrome, you absolutely should treat with anticoagulation and aspirin, not one or the other. They need both because that's what the studies are showing on. But here's the catch. Are you ready? This is literally a very subtle point that I think makes a difference in your patients. The studies were never done on LOVENOX. They were never done on fractionated, it's heparin. It's heparin. The unfractionated stuff is what does this. They've never done equivalency studies with LOVENOX to my knowledge, right? And the difference is that unfractionated heparin has a lot of carbohydrate moieties on the outside that are anti-inflammatory. And we think there's something there. So it's in my mind, it's heparin 5,000 BID plus baby aspirin every day. Would you agree with that?
Either one. There isn't any prospective data to show, but most people would use LOVENOX instead.
It's easier, it's cheaper. It's hard to get heparin now, by the way. It's really hard to get outpatient heparin.
But I thought that they did do a study which looked at heparin and LOVENOX together and their availability and their functionality, but that's only for anticoagulation, right? Not for the pregnancy.
Not for this indication.
Yeah.
Okay.
So that's the punchline of it. So, all right, I'll move on. I know that I have a lot of slides. Sorry. No, my fault. I'm too talkative. I'm sorry. So everything's idiopathic, by the way. 50 to 60% of these patients are going to be idiopathic, okay? So treatment. So, all right, basically this is, so heparin and aspirin, and so I have a nurse who she had severe IUGR in her first pregnancy, and the baby, like her 5-year-old is still like this big, right? And I'm exaggerating a little, but not by much. She's a peanut, and she's had 4 losses since then, and she has a thin, super thin lining on her mid-cycles and everything like that, and she's always had these mildly persistent, intermittent antiphospholipid antibodies. It's never the same one, and it's never really high, and she's never made the diagnosis exactly, but I feel like there's something there, and because she's my nurse, I have no objectivity, and I was like, all right, she got pregnant spontaneously, and I treat her with heparin and aspirin. And I was really proud of myself for giving in and just saying, hey, look, not everybody's in the textbook, and you don't have to follow like every checklist, you don't have to be so evidence-based. Just give her some heparin, who cares, right?
Exactly.
Guess what? She just lost at 9 weeks.
Shit.
I did her DNC Christmas Eve, right? So, Christmas Eve day.
Great.
Yeah, and it was euploid, by the way.
Well, thank God you gave it to her then. Then imagine how you'd be beating yourself up.
That's correct.
Right.
What if I didn't? What if I didn't?
Right, so heparin and aspirin, so it's heparin, not LOVENOX. I mean, I think that's a very subtle point.
Heparin, aspirin, steroids.
So, all right, so, you know, let's talk about this. LOVENOX, so the death knell for anticoagulation, whether it's LOVENOX or deltoxaprine or whatever it's called, or heparin, the death knell for this was this really well done New England Journal article in 2010, all right? They took, it's the death knell for it. This is a really well-regarded article. It was agreed to by everybody. It's one of the few things that the reproductive community, the hematology community, that the MFM community, that we all agree this was a well-done study, and so you don't really have a leg to stand on for empiric LOVENOX and aspirin for unexplained loss or even thrombophilial loss, right? Because it's just not associated.
Names on that.
I know, right? Well, it's actually the
My name on that?
it's a big trial, yeah. Yeah, it's a big trial. So, you know, I'll tell you something near and dear to my heart. When people come to me for losses, I go through probably, honestly, before it's all said and done, 3 hours worth of counseling before we actually get into treatment. Not in one visit, obviously, but over time when I add it up. So, at the end of the day, I'll say, listen, this is idiopathic. I test you for everything under the sun that is evidence-based. All the other stuff is crap, and I'm not going to do it. I say it nicer than that, but that's basically what it is. I said, this is, when people come to me for miscarriages, this is what I have to offer. Are you ready? She said, yes. I have 3 options for you. And actually, anyone who's had a recurrent loss patient, I put this in my letter. Like, I really, like, I'm sure, Rupi, you've seen it like 10 times, I'm sure. But basically, I said, you have 3 options. 1, try on your own. You have no trouble getting pregnant, so to speak. That's what they all say. I have no trouble getting pregnant. You can't stay pregnant. And then come to me when you miss your period, and we'll watch you carefully. I'll throw progesterone at you. We'll do 4 first trimester ultrasounds. Tender, loving care, TLC approach. That actually has been shown in good trials to help.
Yeah.
Literally, TLC is like the only thing we had for a long time. Weekly visits, supportive care, right? So they say, okay, well, that's awesome, but doc, I don't really like that. I'm really frustrated right now. What else do you have? Second thing I offer them is I offer them low-level fertility treatment, right? Ovulation induction, IUIs, things short of IVF. And the reason why I say that is twofold. Number one, it will increase your cycle efficiency and decrease your time to conception. You're in a hurry, you've been trying to build your family for 2 years. Let's hurry up and do this, okay? Also, I do believe in my own heart that if you super ovulate someone, your hormones are going to be a little higher, your ovulation is going to be a little tighter because it's being driven by medicines. And I do think that there's probably higher, like better luteal support when you have like 2 or 3 follicles that have ovulated and things like endogenous luteal support. I think there's something to that. But again, unencumbered by evidence, and I apologize for saying something that's not on a good slide, right?
And ultimately, like I think you hinted at, I think all of us, you know, frequently actually, you got to go with your gut feeling and a little bit of signs that you have that gut feeling, no matter what the studies. We're treating human beings, I tell patients. You know, the books be damned. I mean, every human being is different, and we all have good results. You, unfortunately, you were referring to this 9-week loss you just had, but she just could have very easily have continued. You know, we've all been there. So, you know, I don't think that's unreasonable either to go with your gut once in a while.
Right, exactly, and as long as you're open with the patients, right? I totally agree with you. That's why our patients like us, because we're open with them and we talk with them. And
practice medicine.
Exactly.
I tell patients, you know, and still you said it. I mean, infertility in my time used to be 90% voodoo and 10% medicine. Now it's 40%.
Right. That's a good one. All right, great seeing you,
everybody.
Yeah, absolutely, great seeing you. Yeah, I was talking about you to Jose the other day. But
we had a crazy time in Dallas.
Yeah. So the other thing I offer them is IVF with chromosome screening. So sometimes it feels like it's going from nice to see you. Sometimes I feel like it's going from 0 to 60. That you take a patient who like has gotten pregnant many times. It might be young, but if you offer them aneuploidy screening, I mean, you're going to decrease your miscarriage risk by 75%. 3/4 of all miscarriages are due to aneuploidy. So if you take out those and you only transfer euploid embryos, you're not going to have that percentage of loss. So that's good. You know, those are what things I have to offer, right? So, you know, we're going to, so I'm going to just move through this. So if someone has a balanced translocation, they need IVF with PGD. So now you can give them 99% accuracy that they're going to get a balanced embryo and they're not going to get an unbalanced embryo implanting. So this is actually I get a lot of, what's the right word, gratification from this kind of patient. You diagnose them with the translocation, you say, this is what you need, and then they build their family. It's really great. The only problem is that you have to build probes for this, because their specific translocation has to have a DNA probe for it. It's like a single gene mutation. You have to have their particular mutation. And that costs money, and then they have to do IVF, and then they have to, right? I mean, it's a thing. But this is what we do, and this is what I have to offer, and I love it. Like, that's one of my most gratifying things. This is some older studies use fish, which we don't use anymore. Idiopathic, all right, let's go past this. All right, APLS, here's the study. This is the original study. Kim's not here, but this is the original study in the late 90s that came out, really well-regarded journal, that they did better. They just did better. It was heparin, though, just remember that. But an odds ratio of 3 1/3 with a good confidence interval, that's awesome. That's real. That's still there. That's never been disproved. It's level 1 evidence. You definitely have a leg to stand on there. Unfractionated heparin, okay? Let's see. This is the study I just quoted. No differences in any of these groups. All right, this is just more of the same. All right, so this is what we said. This is where people, like, I think somebody died once doing this. Like, don't do this ever. And I don't, yeah. And then IVIG, come on. Really, this is just like, well, it seems like it should work. Let me throw something at you. So more studies on saying what IVIG infusions.
So prednisone nobody's using anymore.
I would say, I would. Yeah, I would say, yeah. I don't think there's any prednisone. I think I have a study out here on prednisone. So progesterone, look, you can always throw progesterone at somebody. Nothing bad's going to happen. Just so you know, there is one teratogenic effect of progesterone. There's actually a well-known link between progesterone and hypospadias in boys. So it's there. It's for real. The pediatricians know it. The urologists know it. It's not out there in the OB community a lot. And it's not like if you go on progesterone, you're going to have hypospadias, but it's definitely Clomid? No. No.
Is it better to IM progesterone or the oral or vaginal?
I think it is because the studies were done before we had.
Pill. Getting pregnant on the pill with that.
Well, those are all progestogens at that point. They're no longer progesterone. So maybe some of the newer ones have something more to it. Nobody talks about it because while it is a large increased risk, it is still a low risk. It's still a low risk, right? Like 4 times a rare event is still a rare event.
I mean,
right?
How many patients do you treat a month? And how many hypospadias do you have? And almost everybody's on progesterone, correct? Almost everybody's on progesterone.
Like literally everybody, yeah. Like literally everybody, yeah.
Even in the premature labor practices, et cetera, et cetera, et cetera.
Yeah.
And, if you see 2 a year.
I mean, I'll be honest with you, I have 2 documented cases of hypospadias in 10 years I've been out of fellowship. Now, it doesn't mean I don't know what I don't know, right? But 2 patients have made me aware of hypospadias.
Right. No, it's me. We can do it.
So a lot of depression, take care of your patients, we know that. And then, all right, so here is, this thing, is this not? Do you see red on there? Is there any red on there?
Red on there.
The red ones are, the red ones are supposed to be the ones that I agree with, and the black ones are supposed to be the ones that are quackery. So good, not good, not good. All of these, yes, no, no. And then, oh, here it is. Okay, I'm sorry. So that's it. That's what you should be doing. All right. And then that little cheat sheet there is sort of what's on there. And then this is for the boards, but whatever. This is what we do. And then this is what that is. But so there's a misconception out there. You don't have to karyotype the first loss or the second loss. I karyotype every single loss. I just think it's helpful for patients. It's helpful for you in the end.
The POCs?
Yeah.
You do?
I do. Even the first one, it's just my own practice pattern because by the time they come to me, it's a little bit different. But I would suggest it.
I don't think they pay for it.
It's an interesting. Well, so that's really the reason against it. But I will tell you that there is some feeling amongst patients. Well, why didn't they test my first or second losses? Well, if they don't pay for it, then don't do it because then they're going to get a surprise bill. They're going to hate you, obviously.
They're going to have to pay for it.
Microarray stuff is not cheap.
Microarray is very expensive.
Microarray is very expensive. And by the way, did your genetic counselor? There's a lot of coverage around here. There's a lot of coverage. Most patients in New York have at least diagnostic and often have like unlimited lower level treatment stuff, like everything short of IVF. Most of my New York patients, Connecticut, it's a different mandate where you have all diagnostics, 3 or 4 lower level treatments, and 2 free IVFs. So it's a little bit different state mandates, but New York's not terrible. New York's not terrible. A lot more patients have some form of evaluations and diagnostics. And then, I don't know, not much else. This is, I don't know if you've ever met any of my other partners, but we're all really cool and all really nice. And, Well, you haven't met the others. How do you know?
Can you just tell us who they are again?
I'm clearly the tallest, though. I am clearly the tallest, right? So Liam Darris is a founding partner. Spencer Richland, he's actually never been up here, Rupi. I don't think you've ever met him. Sean Williams, so handsome, isn't he? No. He's, people love him. So he's been with us about 2 years. Cindy Murdoch's our only female, but we're all highly estrogenized, don't worry. And she's been with us about 5, 6 years. So I think you guys have, Cindy Murdoch's been up here when we used to be up here in the old Mid-Hudson. Mark has too, and me, the 3 of us. But just to reiterate, we're going to be in, Adele, you didn't hear this, we're going to be in Poughkeepsie. We're going to rent some space in Poughkeepsie. I don't know yet, but it's going to be in.
My building on IBM Road?
I'll talk to you. So we're going to be in Poughkeepsie. We're